4 digits. You don't need to stimulate the thumb all the time. But with a pattern of stimulation that involves approximately 250 hertz frequency occurring fingers every 7 seconds, so occurring at about 1.5 hertz overall for the cycle, but 250 vibrations a second on both fingers, or I should say on both hands, you can produce an effect that he says breaks down the abnormal rhythm that's present in a Parkinson's brain. And that's what I'm going to talk about today. What is the basis of that abnormal rhythm, and how does that stimulation override it and overcome that? So what you might be able to see on the bottom of the slide or in the handout are the UPDRS scores, those plots. And you don't need to notice anything other than the curve is pointed down. So after patients, multiple patients, experience the stimulation in the fingertip, and they're rated with a motor exam, they score better. Their symptoms are alleviated, and it's long term. So all you've done is stimulate fingertips pretty vigorously for several hours, okay? But the people aren't reporting pain. They're just reporting that feeling the vibrating stimulus, and the symptoms are getting better. And it does cause changes in what you can measure on the surface of the brain. That's the image in the middle. If you were to essentially do an EKG, but for your brain, and measure electrical activity up there, you're producing, along with the benefit, you're producing changes in electrical activity. So that's at the heart of the explanation, or why, or how it works. In order to understand it, the basis for it, I need to remind you that Parkinson's disease, the motor symptom, is a condition that involves basal ganglia structures. Everyone in this room heard of the basal ganglia because the cells that make dopamine are part of the basal ganglia. Those cells that make dopamine, they're second from the bottom on the left, the substantia nigra cells. Those are the ones that are lost in Parkinson's. About 70 to 80% of them are lost by the time the symptoms show up that we associate with Parkinson's. By the time you have the rigidity and the tremor, slowness of movement, you've lost 70, 80% of those cells. So our work in saliva, as an aside, is to try to find biomarkers that indicate when someone has Parkinson's before they've lost all those cells. So we might be able to keep them alive long. These are the names of the different structures in the basal ganglia, and I'm going to simplify it further, hopefully. We can divide the structures into the set of inputs from the cerebral cortex, the gray matter you'd see if you look at the outside of the brain. We've got inputs to the basal ganglia, and we've got output from the basal ganglia back to the cerebral cortex. The input structures receive inputs. Not sure if you can see on the left, looking at it, from a lot of different areas of the cerebral cortex. All the motor areas, all the areas that contribute to the control of movement, almost all the sensory areas, especially what's called the somatosensory area. However, I'll point that out because that's critical, understanding why and how the glove works. We can simplify that chain of connection, and I like to use this diagram, even in the medical school lectures, as consisting of a sort of unusual bicycle. So if you want the bike to move forward, you want the bicycle to go forward, you need some action at the pedals. And we can consider the cerebral cortex, where you're coming up with a plan for movement, as the pedals at the top there. They provide a signal to the input layer of the basal ganglia, which is also known as the striatum. And we've got a chain that makes that positive activity translate into positive activity. Then the chain wraps around a brake. The brake is a problem in Parkinson's because the brake, by default, happens to always be on. And we have to overcome the brake in order for any movement to occur. There's a rear sprocket that the chain has to pass through before it connects back to the cerebral cortex. But when it does, you can get a positive feedback loop going on. And that means that any activity, any thought, any notion of moving the finger up in the cortex can have a positive feedback through the basal ganglia circuitry when it's working correctly. Now, why is there a brake? Why is the brake always on? Well, we don't want constant positive activity all the time because we'd be fidgeting and moving. And I'll go into how I think that might be an operation of what's happening in the case of tremor. But normally, some brake activity is applied, so we only let the most meaningful patterns come through. That's the whole purpose of this circuitry. So when you come up with a new plan, a new skill, you're learning how to use the speed bag, you're putting all these new patterns of activity together, and you're trying to assemble a motor skill, you use this circuitry all the time. Dopamine is like the oil on the chain. So dopamine doesn't make the movement at the beginning. Dopamine actually facilitates the action of this circuitry, especially if that action leads to reward of any kind. All right. So why is the brake always on? To filter the noise, to promote the selection of the most meaningful behavior. I'm going to simplify this into this line diagram. I use this all the time. So hopefully I'm going to walk you through it and it'll make sense. If you look on the left, let's focus on the left. There is a cortex. That's like the top of the chain. And it provides a excitatory signal to the input layer of the basal ganglia. We've got an input layer and an output layer. The input layer projects to the output layer, and the output layer projects back to the cortex. So this is just like that chain that I drew. What we have, I can't show the pointer on the screen, just a second. Now I can. When the cortex excites the input layer, we have in what's called the direct pathway, an inhibitory signal. And this inhibitory signal projects to the output layer, which is the brake. The brake is always on. And so cortex excites this cell, makes it more active. This inhibits the brake. It helps turn the brake off. That allows the thalamus, a structure in below the level of your cortex, to provide positive feedback to cortex. If you want to understand what the net effect of these activities are, you can just multiply the math signs against each other. Remember back in junior high, positive times the negative is a negative, but two negatives times each other is a positive. So you can trace what's happening through this circuit. Cortex positive times a negative in the input layer, that's net negative. So we have a negative times a negative, that's net positive. Positive times the thalamus feedback is positive. So the direct pathway has positive feedback. It makes those thoughts, the idea of moving your finger, more likely to happen. It can help overcome the brake. However, there is a pathway called the indirect pathway that uses a structure called the subthalamic nucleus, which is really important to understand Parkinson's disease and the basis of its treatment and the basis of the glove. So the subthalamic nucleus is actually subject to increased activity in the indirect pathway the same way the thalamus was the benefit of that double negative, the subthalamus now becomes more active in the indirect pathway. And the subthalamic nucleus doesn't project back to cortex. It doesn't provide positive feedback. It projects to the brake instead. So the subthalamus makes the brake more active. The direct pathway, it's like one of the houses of Congress. It's trying to have positive feedback. The indirect pathway is the other house, all right? And they're competing with each other all the time. Who wins? The indirect pathway wins. The indirect pathway wins because this isn't the full story. We need to fill in another line or two. So first of all, let's put dopamine in the system. And dopamine, whoops, I actually am missing the dopamine box right there. Dopamine, if I drew the cells there, influences the direct and the indirect pathway, but it does so in opposite ways. So dopamine acts on a different type of receptor in the direct pathway than the indirect pathway. Dopamine, through the receptors, will promote the activity of the direct pathway. Dopamine will promote positive feedback. In the indirect pathway, it acts on a totally different class of receptors, and it will try to inhibit the indirect pathway. So dopamine is your friend. If you like positive feedback, dopamine is going to facilitate the direct pathway and oppose the indirect pathway. So you can get more positive feedback. There's another pathway up here called the hyperdirect. And you might notice there's a line that goes from cortex right to the subthalamic nucleus. And that's real important because this drives the subthalamic nucleus to have increased activity. Lots of areas in the cortex will have this increased activity, translate to more subthalamic nucleus activity. And that's going to mean the brake is more active. It's just always on. So it's an interesting system. We're going to revisit that in a moment. I want you to understand, if I can now, jump. We're stuck. No, I'm not. Yes, I am. Here we go. Too far. That's the default circuit. How many of these circuits are there? There's a circuit for every type of behavior. Every area of the brain is using this circuit. Every area in your cerebral cortex. If it's a motor area, that exact diagram we just drew, there's one for your hands, there's one for your face, there's one for your legs, there's one for every part of the body you can control voluntarily. There are also circuits for your eyes, moving your eyes around. You wouldn't do that without these circuits. And dopamine will help you do it. It will help turn off the brake so you can do it more meaningfully. There's also those positive feedback circuits with emotional areas of the brain. So what functions do these circuits apply to? Every function you can think of. Every part of your brain is using the basal ganglia circuit and benefits from dopamine. There's a little bit of evidence here, and I'll just show you how in the oculomotor loop, if you're going to make an eye movement in one direction and we record the activity in the cerebral cortex, it's going to be excited. Here's the input layer of the basal ganglia. That's excited. That's going to turn off the brake. You'll see there's less activity. This is a measure of activity. And the target of the brake would be the thalamus. That would be this structure here. This is going to be more active. And it would be positive feedback to the cortex, and you get an eye movement as a result. So over here, you can just barely see there's the dopamine cells drawn in for good measure. Yes. Yes. We're going to go over that immediately. So hold on. That's a question. Definitely going to answer that. I want to tell you how or show you what dopamine does in this circuit first. That's right. Everyone's got a braking system. So back to the eye movement analogy. If you're going to make an eye movement, let's say you're going to make the movement to a target in the periphery. Whoops, that was too fast. So if something flashes on the side and you move your eyes to it, okay, and you move it correctly, you would have what we call a saccadic eye movement to that target. And interestingly, you could do this in all four directions, and you could record the activity in that input layer of the basal ganglia, no matter where the target was. You could find a sensory-driven visual response in the basal ganglia. And you'd have a whole population of cells responding to where that target was in space. The same way as if you were going to reach to it, wherever that target was. But it turns out that the basal ganglia change what they pay attention to, whether or not it's rewarded. So in this paradigm, if the monkey was trained to do it and did it correctly, made the eye movement to the target, he got juice. And after one or two trials, immediately the basal ganglia cells latched onto and changed their activity to respond to the direction that was rewarded. Even if the stimulus was in this direction, but you had to move the eyes in the opposite direction, it was the movement in the opposite direction that the basal ganglia cells were tuning themselves to. So whenever you think of the basal ganglia, you think of the contribution of dopamine. Dopamine tunes activity in the basal ganglia to reward, to successful completion of motor acts. That is a take-home message, okay? It's not only occurring in the input layer of the basal ganglia, it's actually possible to see the same tuning in the dopaminergic cells themselves. So the bottom set of recordings, that comes from the dopamine-producing cells, and they project to the input layer. So the whole network of basal ganglia is tuned to shape its activity for things that are rewarding. Shaping activity of large groups of cells is how the brain accomplishes behavior. Spoke about cortical areas that control movement. There have been a lot of studies, decades now of studies, where people have recorded populations of cells on the surface of your brain and determined that, in fact, one individual cell doesn't really control with high precision what you're going to do, where you're going to point, or how far you're going to point, but groups of cells acting together in synchrony, you can absolutely know what they're trying to encode when they're firing as a population. So there's population tuning. And in the motor system, we can say for specific directions and distances of movement. And we can even say for specific muscles and sets of muscles. We find evidence for that. So if you record activity, if you put just a grid of electrodes over somebody's brain, and you send the signal that you're recording to a computer, this is so predictable that you could drive a robotic device to make the movement that the person's brain cells, the population of brain cells, are trying to accomplish. And that's really dramatically demonstrated here. If I can change. There we go. This will play. Please play. There it goes. So this is Jan. She has activity in her motor areas being sent to a robotic arm, and she's feeding herself a chocolate bar. And it's because there's large populations of cells that are sending a signal, an organized signal. This was her very first attempt to feed herself a chocolate bar. This is her second attempt. She figured out a trick. See her trick here. Quickly pull away so you could keep the chocolate in her mouth. But Jan wasn't always like this. Jan walked normally. So I'm not sure if you heard that or not, but she said one small nibble for a woman, one giant bite for BCI, which is brain-computer interface. Populations of cells organize and accomplish motor acts. The basal ganglia loop promotes the selection of activity and help the synchronization of these populations. If you don't synchronize populations of cells, you don't have the ability to predict anything about what the brain's trying to do. Now let's complicate things. They're recording on Jan's cortical motor areas. She's got maps of her hand and her arm in more than one place. There are multiple maps. In fact, there's 5 maps of your hand, your arm, in the motor areas concerned with moving the hand. Now, some of those maps are better than others. You have the primary map, primary motor cortex. That's got the best connections to your spinal cord. But you have a lot of auxiliary maps, and some of those don't represent all the digits exactly the same, but they're independent maps. And each one of them connects back to that primary map. And something has to make these maps fire together. Because if they're all trying to do different things at the same time, or if they're all trying to do the same thing at different times, chaos, right? You don't get synchronized patterns. You don't get the ability to feed yourself. So there is the motor map, just in the lower right of that screen. That homunculus, it's called, is created in proportion to the amount of your brain that's devoted to motor control of different body parts. What parts of the body win? Look at those hands, right? Those are incredibly overrepresented in your brain. Your brain space for primates, hands, number 1. Face, number 2. Hands, really number 1. There's a lot of real estate that we have to synchronize activity. And it doesn't always work that way. And Parkinson's, what we've done is we've lost the cells that make dopamine, at least some component of it. And so you can draw the red X through there. What that leads to, loss of dopamine at the input layer. And you can see how the double negative is lost on the direct pathway. That makes the brake more active. And it also interferes with the opposition of the indirect pathway. So on the right side, the indirect pathway now facilitates that subthalamic nucleus. You're going to get even more braking power. And that causes that positive feedback we wanted, drops to a trickle. The issue with that is we need that positive feedback. That's our go signal for your motor system. You lose that go signal, you can't move, let alone get the different motor maps acting at the same time in the same way, synchronously, to produce organized actions. So the hyperdirect pathway that's there directly to the subthalamic nucleus, that's not really affected by the dopamine loss. It's always going to be promoting that subthalamic nucleus overactivity anyway. So the best guess of the consequences of what is happening here, I'm going to try to provide this to you. Because there are many motor mounts, if you lose that ability, that sustained cortical motor area activity, it can't organize. And because you've got cell-to-cell connections, all those areas up there, if they're not given enough juice, they can't fire together. They're wired together, but they can't fire at the same time. Their activity is not synchronized. And what does that cause? The best analogy that I can use is with acoustics or sound, okay? So imagine, you can maybe make it out on this trace, but imagine there's a frequency, we'll call it 40 hertz. You wouldn't actually hear that, but it's too low frequency for you to hear. But imagine there's a frequency oscillating at 40 hertz. And now let's put another frequency of 20 hertz. If we put those two frequencies on top of each other, you'll notice you can get a dissonance curve that's produced on the bottom. When they happen to coincide near each other, but not quite, you get an even larger, you get an addition of the signal. It's never going to be faster than the smallest, or I should say the slowest frequency that's there. But it means you can have lots of high frequency things happening, and you can get a low frequency, unusual dissonance discharge. Now that's just with two inputs. Let's change it. Let's put all 5 motor maps firing slightly out of time with each other, not synchronized. And that's what would happen if you had 5 inputs firing high frequency, but slightly different timings. Look at what happens. There's this superimposition of this larger dissonance oscillation. That's the big trace. Those 5 frequencies, those 5 populations, different motor areas, those are the little, fast ones. And you are producing this large dissonance. And I would suggest, and some evidence backs this up, that that is how tremor is caused. Because in Parkinson, you can't synchronize the real estate. Different hand areas, in particular, the hand, are doing things slightly out of tune, out of time with each other. And you're going to produce wave collisions that will yield a very predictable tremor. Some evidence for that, you can read the title, Electrocardiography Reveals Beta Desynchronization in Basal Ganglia Cortical Loop During Rest Tremor in Parkinson. The specific tremor, these are traces from 3 people that were in the study. If you look on the top, that's actually the spectral analysis of the frequency of the tremor. And the very first curve, if you know anything from high school physics, it still sticks there. The fundamental frequency that's there is right around 5.1 or 5.2, ranging up sometimes to 6 hertz in most of the subjects. So you're seeing a frequency of that dissonance from the last slide occurring at that common range, so really 5 to 6 hertz. That is a different frequency from what you see if you were studying essential tremor, or people that have damage to the cerebellum when they try to reach to things and their hands are shaking. Parkinson's tremor operates at a different frequency. It's a different part of the brain that's involved in making those oscillations happen. And that's the explanation for it. Now, I can tell you that the fundamental frequency of movement, when cells are supposed to be cooperating together, you're trying to achieve 15 hertz. So right in that 14, 15 hertz. That's what you want the cortical motor areas to be operating at. That's what you're seeking the basal ganglia to help promote. And what happens instead is a breakdown when things aren't synchronized, and you get a tremor produced. And you also can't overcome the break. So having said all that, now you understand the basis of how all treatments of Parkinson's disease are based on the model that I shared and explained to you. Pharmacologically, we try to replace the dopamine because the dopamine works on those circuits. It will try to facilitate the positive feedback of the direct path and inhibit or provide a counterbalance against the actions of the indirect path, which is trying to increase the break. We either replace the dopamine using a dopamine precursor, like L-Dopa or various versions of it, or you give drugs that act on the same receptors that dopamine acts, so those are the dopamimetics, or you give drugs that help prevent the breakdown of dopamine. So there's more dopamine available in the basal ganglia. And this can be effective, as you know, for alleviating the slowness and the tremor. We can also look at the surgical treatment for Parkinson. Original treatment involved taking the break out of the picture. So there were FDA-approved treatments that could be done where a neurosurgeon would go in and make a lesion in the break. And that would work as long as you put the lesion in exactly the right place. Because if someone doesn't have facial symptoms, or you put the lesion in the part that supports cognitive function or emotional function, you could produce the symptom, a side effect. It's not in the area that you were supposed to be targeting. You could also put in cells that make dopamine. So transplanting cells in. There's a lot of promise in that area with stem cell research now. There's a huge possible future of doing that to restore dopamine levels. Difficulty is getting those cells to integrate into the circuitry because you're putting in a foreign brain cell. Even if you grew it from a patient's skin and it's their own, they're not going to reject it. It doesn't mean it's going to integrate into the circuits and function like the original brain cells would. And the last thing is pacemaking. So instead of lesioning the break, what if we changed that pathological activity level profoundly? And we do know that this works. I'm sure. I'm going to try to show that. The difference when the deep brain stimulation electrode is on and firing versus when it's not, very dramatic. And I'm sure you've seen other videos. This was sort of one of the original or older ones, just extremely effective, promoting a near normal appearance in a lot of patients. So how does that work? There's the electrode on the left of the slide, and it's pointed either at the break itself, that's approved. You can put an electrode in the globus pallidus, or you can put it in the subthalamic nucleus. That's actually more commonly used. And that's the subthalamic nucleus that is exciting the break in the first place. So the break wouldn't be overactive if the subthalamic nucleus wasn't really making it hyperactive. So you're not lesioning. You're not doing anything to permanently alter the circuitry here. You're having a pacemaker effect. Just like an abnormal rhythm in the heart, you've got in Parkinson's disease an abnormal rhythm of firing in the break. And we're trying to control that, put it at the right speed. So how does the glove effect work? How does that break the abnormal patterns, abnormal rhythms? That's requires explaining just a couple more things to you. On the sensory side, so we spoke about motor systems. Let's talk about what's in your fingertips. in your fingertips, you have specialized what we call mechanical receptors for detecting mechanical stimulation of different types. And there's a number of their names appear on the right, and they're in a diagram on the left of this slide. But you have Merkel, Meissner, Paxinian, and Ruffini sensors that you'd find different amounts of in the non-hairy part of your skin, especially in the fingertips. And as the example on the right shows, you can maximally activate those with different types of stimuli. Why do you have 4 different types? Some of them are more responsive to high frequency stimulation or low frequency stimulation, some of them to fine points, and some of them aren't really responsive to fine points at all. If someone was rubbing their fingers across a sheet of paper with Braille type on it, the examples on the right indicate the responses of the 4 different receptor types you find in your hand on the surface of the skin. So some of them will reproduce the Braille pattern really well, fine precision. They respond very exactly to what they're experiencing. But others, this one in particular, on the bottom trace on the right, called the Paxinian, just detects when anything's moving whatsoever. It's like, well, it's actually shaped. It's over here on the left of the slide in blue. It has a big shape like an elephant ear. So if you think of a pachyderm, Paxinian corpuscle, it's like a giant antenna that detects any type of vibration whatsoever. So when you're rubbing your fingers across a bumpy surface of any kind, it could have Braille or it could appear to be smooth, it's going to detect that. Why? Why do we have these sensors? What's that useful for? Motion detection, right? If you're maintaining posture and you slide your foot, that's the vibration stimulus to your foot. And that information that the foot is moving or the hands are moving is important for you to be able to respond to. So we've got these sensory devices. Some of them, this is a slide. I don't quiz the medical students on this. I won't quiz you on it either. But the exact frequency that Paxinian corpuscles are most receptive to corresponds to the frequency of stimulation of the fingertips in these gloves. And this is not necessarily an accident. That same frequency, the question prompt at the bottom, which is most sensitive to cell phone vibration? It is the Paxinian. So the people who manufacture cell phones were able to determine the frequency that they stimulate that people would report, my phone's ringing most frequently. And it's that same frequency. So this frequency in the fingertips corresponds to the exact frequency range that you are most sensitive to. And your cell phone takes advantage of that. Most of the manufacturers fall right on that same area. Now, when you stimulate at that frequency or any frequency, when you stimulate the fingertips, where does that information go? On the left of this image, you've got a fingertip. You can just make it out kind of pointing. That information goes up the nerve path, goes to the spinal cord, and it goes up to what we call the primary sensory cortex. That sounds important. Primary sensory, because you also have a secondary one. But let's just focus on the primary sensory cortex. If we enlarge that part of the brain, you can see on the right of the slide that there's a sensory map. Just like there was a distorted motor map, there's a distorted sensory map to the body. So who wins again? Hands and face, right? Now they've changed, right? The face is a little bigger, the lips, right? A little bigger than the motor map. The hands are a little smaller than the motor map. The representation that you see in the sensory homunculus that's displayed there is proportional to the amount of fibers and receptors that you have in the periphery. because that information isn't lost. The importance of having so many receptors specialized to detect those things is maintained when you move centrally. So we create an internal representation of the external surface of our body through this. And that map has multiple representations. There's a face, every single part of the body has its own representation. But it doesn't stay there. This map is mobile. So there are dense projections from every body part that you'll find represented in that sensory strip of your brain to two important places. And one of those is the motor area. It's a direct connection. So the hand area, they're receiving the sensory information, goes to the hand area where the motor signals are being generated. Same part. There's not a remapping. It's the same corresponding part. So if the hand's experiencing something, the motor system knows about it. In fact, some neuroscientists philosophize or theorize that the motor system exists to optimize the sensory input that we experience. The whole reason we have a motor system is so we can make better sensory input. That's controversial. I'm not going to agree or disagree, but that's how tightly coupled they are. Sensory right to motor. That's a highway. It also projects to this area of the basal ganglia that corresponds to the same area that the motor areas project to. So the hand area of the cortical motor areas that projects to the input layer of the basal ganglia. We've also got projections arriving in those cells from the sensory strip, hand representation. So it's this triangle. We've got sensory, motor, and basal ganglia. It's getting both. So you have a lot of opportunity at the cortical level to reinforce this activity wave, and that translates into more activity in that positive feedback loop. So why does the glove work? The glove works because you've got so much direct input from your periphery, especially in the fingertips, to the sensory cortex. And that drives activity in the motor areas, even if you weren't thinking of moving, but you probably are. It also drives activity in the input layer of the basal ganglia that can overcome the lack of input from a cortical motor area in part, or the loss, the reduction in the input, so that you can really engage positive feedback. Recording the activity of the subthalamic nucleus has been done during the stimulation of the equivalent of the fingertips using rat models. So what's the equivalent of fingertips? You use the whiskers, okay, and you stimulate the whiskers in a rat at these same frequencies. That's what they use to tell textures, right? The same way we use our fingertips to determine what the surface features are, they're using whiskers. You will change the activity in the subthalamic nucleus through this exact path. We know that happens. And that's what's being examined right now in neurosurgical procedures in people undergoing DBS stimulation, where there's an electrode being placed in the subthalamic nucleus. Now, with the studies coming out about the glove, they're exploring the activity patterns that they can observe in those cells with sensory stimulation as well. Because people are awake during these procedures. You have a local anesthesia, but you're awake when you're having the electrodes put in. So we're really excited, I think, in the field, I say we, basal ganglia field. I've been in that field 30 years. We're really excited about this new potential treatment because it exploits the circuitry to the maximal extent and produces a very observable change in the activity of a cell, but you haven't had to resort to a neurosurgical procedure. The neurosurgical procedure is reversible. If all you're doing is implanting an electrode, you can remove it, of course, but it's not as reversible as taking a glove off, right? So that's pretty much what I wanted to deliver as the message. What have we learned? We've learned the basal ganglia help you create motor synergies. When you put a lot of synchronized activity together, you can build motor repertoire, habit. You can reinforce synchronous activity in your cortical motor areas that combine muscles in ways you didn't before. When you do that, that's a motor skill. And basal ganglia positive feedback loops promote acquisition of motor skills, learning how to use a speed bag, okay? Or jump rope, which I am horrible at. If cortical activity is insufficient, you never set up these large populations of synchronous activity. And you can't overcome that hyperactive break. So in the case of Parkinson's, when the dopamine's lost, that's really going to be emphasized. Dopamine will always try to promote this positive feedback and oppose the break. It makes it difficult for that positive feedback loop to exist. Not enough dopamine, not enough positive feedback, not enough synchronization. Asynchrony results can produce those dissonant waveforms, the tremor, and will also make it difficult for movement to be initiated in the first place. Slowness of movement, bradykinesia. Sensory signals could really help overcome that if they're strong enough. And they can produce long-lasting changes. Your basal ganglia systems that I said exist for habit learning, that's not when you're trying to learn habits, you don't want to forget it the next day. That's not how we've been designed. When these synchronies have been established, there's what's called a long-term adaptation. So the cells that are parts of these circuits, they remember. There are cellular changes in protein synthesis that alter the synapses or the connections permanently once you've learned the skills, once you've learned new synchronies and you've created those patterns. Same thing could happen. You could have long-term, hours, days, weeks of beneficial adaptation from the right type of stimulation. This is my best guess why I believe the glove has some opportunity to be beneficial. I don't see abnormal outcomes, and I don't see any harmful outcomes from what I've read. I do see that there are some mimics out there, and I think you'd want to be very careful about just buying any old glove off of Amazon, because you don't know what the frequency of stimulation is doing to your brain. So Dr. Toss, Professor Toss, has researched this. The specific frequency was researched in a monkey model of Parkinson's. That same frequency was used to stimulate the subthalamic nucleus in the same way. That is what's being used on the fingertip stimulation gloves that he developed. But obviously you can't buy these days. Right? These are in clinical trials. I hope the FDA would consider a fast track designation for this if there's truly no harm that is deemed possible from this. But I'm not sure there couldn't be possible harm because you have to have enough subjects in a study to rule out things. If somebody, for example, was prone to seizures in the past and they started having this stimulation activity, it could be like light flickering at a certain frequency. And so there always could be risks for certain people in certain situations. And if you only have small studies, you may not uncover those. So scientists have to take their time, but it doesn't mean we have to be patient about it. So, a double entendre there. Happy to answer any questions.
Given that the stimulation of a certain frequency, that technology is not very sophisticated and it's not very expensive. It's a waveform generator.
That's right.
with electrodes on the end.
That's right.
So
So
we're gonna start to use TENS machines on our people.
the TENS adaptation, that's been described. There's DIY fixes that have been described to do that. I think if it benefits somebody, it's certainly worth exploring, as long as they don't have. I would say the seizure might be the biggest sort of red flag in my book. There are other benefits of the stimulation as well. And when you're stimulating the sensory side, as TENS does, pain is alleviated, and rigidity. Because some of the stiffness symptoms have been reported to be diminished with the right stimulation parameters as well. And it turns out the subthalamic nucleus is part of the circuits in the brain that help process pain information as well. So this may be, a very fruitful avenue for exploration. And nobody's saying, nobody's claiming, not even Professor Toss is claiming, he's got the one frequency everyone has to use, okay? Because we're still learning so much about it and fine-tuning it, tuning it to different people, depending on their body size, depending on their, how active they are, maybe their age, their muscle mass. That ultimately is likely to occur like it does with DBS. The exact tuning of the frequency of stimulation is always modified and sort of customized. So,
Is there any projected effect on dopamine cells themselves?
that's a great question. So the long-term adaptation that I was mentioning changes dopamine cells. There's no question. DBS, so when you downregulate that overactive subthalamic nucleus, that's been shown to extend the life of dopamine cells. And that's a little hard to say it's a pure effect because it's effective and you can give people less L-DOPA. And we do believe that the longer somebody stays off L-DOPA, the better off the surviving dopamine cells are. So it's both things can happen simultaneously.
Maybe you could clear up a misconception, if it is. Clearly, there are dopamine cells not producing. And the question that I think I have read is whether they actually have died or they're just quiescent.
When I look at the postmortem brain, the cells are gone. So when I say 70%, 80%, they're truly dead and gone. Before they die, they're dysfunctional. When they're dysfunctional, they very well may not be making dopamine. And so, or the normal level of dopamine, or releasing it in response to the same signals in the same way. So their patterns of activity will be altered, even if the cell is still alive. Yeah.
All right, I'm done. You guys.
Yeah. No, it wasn't. So there was many decades ago, there were stories from people riding the train, from people that were using jackhammers, things that would vibrate at high frequency. If it happened to be somebody with Parkinson's, they were claiming they felt a lot better. Now, that was the impetus for some of his work, initial work. That's been tried too. So there's been a lot of whole body stimulation work that's been done, not nearly as effective as focused stimulation, and particularly the fingertips. And hopefully you could tell by the math, the distortion, why that's the case. The hand, right? Could you get this effect stimulating the face? Probably. Most subjects with Parkinson's don't have a facial tremor, some do. But more often it is the hand that would be involved. So this makes it an easy target. If you're trying to alleviate the tremor, the overall slowness of movement, difficulty initiating movement, that may not matter as much if you're using the hand. So let me tell you one thing about the subthalamic nucleus. It has a wonderful population of cells that loves to synchronize. So almost any place where you stimulate, whether it's the hand, the face, the leg, it will cause synchronous activity to start to develop in the whole structure. So it's kind of like the heart in that regard. It actually has some of the same types of channels that heart cells have, so that it will fire in synchrony, regardless of whether you're using the hand or the face or the feet. So personally, I would be curious to see if Dr. Tass or other innovative people come along with something that could stimulate the feet. That might be more tolerable. You could go about doing your normal activities with your hands and no one would know. Your feet were experiencing a little foot massage on the tips of your toes. But that's a great question. Yes. Well, not directly, but I would say definitely indirectly, because if it promotes an improvement in motor function, you're able to stay more active. If it promotes more muscular activity, then you're more likely not to suffer the respiratory problems that can occur if in late stages you're unable to cough, swallow, things like that normally. But it's aspiration pneumonia we worry about a lot. It more than prolonging the life, I think it would also promote the quality of life more than anything. So I am not a snake oil salesman. I have nothing to gain from this glove. I don't think anybody does at this point, because you can't buy any options or stocks or whatever in Stanford Medical's products in this regard. But I will call myself a very, I think, critical fan. So if I can use that word with the other word. So looking at all the science under it and trying to understand, is it bogus or is there an explanation? If there's an explanation for why it works. Yes. So I imagine, I don't know, but I imagine Stanford Medical has many spin-off companies, and whether Dr. Tass himself starts a spin-off or whether he allowed one of the spin-off companies or startup companies to option the intellectual property around this specific device, anything's possible. Or another company that and has a reputation for good stimulation devices. Yeah.
5 minutes.
That's right. So maybe Medtronic or something like that. Hopefully it wouldn't be a company that would buy it and then quash it, the technology, because they're so far invested in electrodes being put in the brain. And I don't think that could happen. So, yeah.
I have a couple questions.
Yes. So high intensity focused ultrasound is another way to avoid an open brain surgical procedure. And with the right devices, you can make a lesion somewhere. Lesions to treat Parkinson's disease can be beneficial. The break is a target for lesions. Ultrasound, high focus ultrasound can be used to target that. But what happens when you've destroyed tissue is you have inflammation. You can have a spread. You can have collateral damage. And so most neurosurgeons would probably advise you against that if you were considering that choice because of that. And putting an electrode in doesn't destroy tissue like a lesion does. The other target for the ultrasound and it's more commonly used in people with essential tremor, is the part of the thalamus that receives input from the cerebellar circuitry. If you go in and you make a lesion there, then you can control that tremor pretty well. But collateral damage, of course, is always a possibility. It is on the tips of the tail. Not in the traces that I've seen to avoid the. So I suspect that it wouldn't matter if you got so much real estate in your brain receiving this excitatory synchronized discharge pattern. If one digit was missing from that pattern, you'd still have enough to cause synchronization to spread. And that's all you're really trying to achieve, synchronous activity. So, yeah.
One thing with the high school is, if you ever see a picture of where you're focusing on something, you come to one focus, defocus. Target area that is outside of known information. Your area of radiation is plus with the high school, the electrode taken away, the electrode not quite right, it's something on moving the position. High school.
Yeah. It's a little leery on that one, except in some situations. Because I mean, you could imagine somebody with severely debilitating essential tremor, maybe of an advanced age, wouldn't want an open procedure. Maybe they can't undergo the anesthesia, but they could sit for a focused ultrasound if it was going to be considered to be really beneficial in their situation. Yeah. Well, the hands would be a safer bet, right? Based on the fact that the paper's already out. There's more real estate, but we use our hands all the time. And so I would lean towards another part of the body that could be stimulated, just for practical consideration. So, but we need the science, we need the studies done on it. No, the hand rule, sorry. So that's why we don't sign our names with our big toes.
For eventually people want access to this technology. They the range very but
Don't do that. It's a long bus ride. And they may reject you, but certainly if you reach out to them, if they're still taking phone calls, because there's been obviously a huge wave of excitement and interest in the technology. What really ideally would happen is a multi-site,
what would be the potential for having this out here?
you would simply need the movement disorder specialist or neurologist who had an IRB that was approved. So that's a protocol involving the protection of human subjects. You have to file a protocol. Even if there's a protocol for a study that's approved in Stanford, it doesn't mean it's approved here in Syracuse. But for example, if I was a treating physician and I filed a protocol, it did get approved, there's nothing preventing me from having subjects in, doing a full workup, having them wear the gloves, make them the same or as similar as possible. There's nothing preventing a physiologist from creating a mimic of those gloves as closely as they can and trying to reproduce the findings. That's what scientists do. We try to show results are reproducible, and that strengthens the observation incredibly when it is reproducible. So multi-site, whether it was part of the original research group multi-site studies really do need to be done. And there are some being done in other countries that you can see. But the stimulation frequencies and the parameters, it's a Wild West show. So people should pay attention to exactly what Dr. Toss has been using, what he used in the monkeys, in the brain. And I think everything would benefit.
Yeah, I think it's worth noting, he's been at this for 17 years.
Mhm. Yeah.
You have to be awake when you listen, or can you be sleeping and whatever it was?
If you're sleeping, you wouldn't need them. You wouldn't need to burn the batteries or run the power. You can sleep, and if your slowness of movement in your sleep, that's a good thing, right? And no, so you would want to be awake when you're trying to engage in motor actions, but you can't because the brake is too active or the tremor is interfering with things. That's when you benefit the most. Yes. That's right. That's right. There's the after effect because of those long-term changes that take place in the cells themselves. So that is a benefit of wearing them for many hours. So you would benefit during your sleep. You'd sort of be sleeping off the benefit of wearing it that day or previous days. But over time, your system would relearn. It would remap the strength of connections, and its ability to synchronize would be modified. I think it would be just like a motor skill acquisition. First, when you learn how to use the feedback, you worked on it not 4 hours a day, but you worked on it, maybe 40 minutes. And then you came back the next day, maybe you were a little better at it. You came back the next week, you were a little better at it. So the long-term changes, I think, could occur that it would probably show continual improvement up to a certain point from continual use of that. That would be truly radical. I think you would maybe an earlier Parkinson, earlier phases. If you could catch someone at the earliest stages and maybe try something like that. Maybe. With deep brain stimulation, patients have been able to go off the L-DOPA because their motor symptoms are alleviated by the stimulation. But what happens in that case is the other circuits in the basal ganglia aren't being stimulated by the deep brain stimulation. Those other circuits are needed for the will to do anything, the desire to do anything. So you get people that are just sitting around, they're capable of moving now because their motor systems are stored with those deep brain stimulating electrodes, so they don't want to do anything. And so you still keep people usually on a little bit of L-DOPA or dopamimetics to improve the overall function. So I think we may be in a similar situation. We'd want to possibly continue a trace level of stimulation on an ongoing basis.
Question for you.
Yes.
I want to ask more of a causal thing. Would it be possible, listening to you talk, it sounded as though somebody could hurt their back in an accident or something, or a surgery, to bring on early symptom departments. Is that possible?
Yes, if somebody's right on the cusp of showing symptoms, it's very frequent for a traumatic event of some kind to lead to the first presentation or manifestation of the symptoms. So that the way that your brain circuitry respond to the stress, it could be an infection, it could be an injury, it could be a stroke-like event. The way that those dopamine cells respond would determine. Yep. The vibration plate machines, like you could sit at the fair and have a foot massage. It's a great question. I'm not going to say no, but I can't give you advice to.
If you already have a deep brain stimulator, can you use it too in tandem?
So this is a question behind me. I don't have a good.
That's on Zoom, sorry.
I think that the foot stimulation could work. It would certainly be very profound stimulation frequency with those foot massagers that you had to drop coins in at the fair. I don't know if it's the right frequency, but the question behind me was, could this work on somebody who already has CBS electrodes in? And the answer is, I'm not sure, but I'm almost positive that Dr. Toss has probably encountered that situation. But in theory, someone with effective deep brain stimulation might not benefit more just from fingertip stimulation. If it's working through the same pathway, ultimately, it may be sort of redundant. But could have the electrodes removed or potentially turn the electrode off and turn on the fingertip gloves and see if you mimic the benefit. And that could be pretty interesting. 250 hertz. So 250 vibrations a second. Your electric toothbrush is right around 15, by the way. So that may not work very well for you guys, but yeah. They're definitely being organized now. Yes. Yes, they're being organized now. So Stanford isn't just a case study though, it's a multiple subjects.
So there can be other.
Yeah. They're expanding their studies. And Stanford Medical has lots of connections throughout California.
In New York State.
I have not. No. But you can go to clinicaltrials.gov website and you can look up a key term search and you can try to see if anyone is out there.
This experience at Stanford is helpful. When you feel this was going to be approved by the FDA.
That's a great question. The days of emergency use authorization are now moving behind us. If it gets a breakthrough designation, it can happen much quicker. It could happen in a 6 to 12 month timeline. In the absence of that, it is probably you're looking at 2 years.
Stanford is projecting 2 years.
Yes.
Is there a tolerance to that?
Oh, I'm sure there is wiggle room around that. Yes. The 250 hertz is optimal because they chose it first and sort of did the work around it. But it is variable. If you look at the psychophysical frequencies for people with the cell phone, I'm reaching for my pocket or my cell phone sometimes is, the people vary slightly in the frequency that they report the strongest. And that's where that psychophysical experimentation has been done a lot. You guys all felt the phantom vibration of the phone that's not really there. You guys are so tuned, your cells have adapted. That's what we're talking about. You've experienced that vibration in that part of your body enough time that there's this expectation of that stimulation. You're ready, okay? You can put a device or an app, I should say, on your phone. There's some vibration frequency apps, and they'll actually tell you if you just set your phone on anything, or you could put your electric toothbrush on it, you could put a drill or anything, whatever you want. It has a vibrating or oscillating frequency, put your phone on it. You could put it on your hand if you have a tremor or your leg, and it'll show you what your frequency of oscillation is, or that device is, if you're curious, what frequency in your house, what appliance is vibrating at that frequency, in case you don't want to burn your cell phone battery all the time, trying it out. But those motors are really tuned in that range, so probably you're close.
Really want to thank Frank for coming in today. We got about 25 people at home, we've got about 60 in here, so Frank can now put on his resume that he spoke to the largest group of Rock City boxers ever assembled in the worst venue ever. And I was to promise Frank, and you guys can hold me to it, when we got our new building, it's going to be the best venue ever that he's ever spoken in.
Ah, a pleasure, and I wish you guys all the success in the potential new move on the expansion. That's really exciting. So I look forward to seeing you guys at the next conference and any other activity.
Thank you.
Any equipment interested in the people who had to leave PSP? Do you project that it would have a similar effect? Oh, what's your knowledge?
It's a
Which way-
very different situation with pathology. Good.
Yeah.
But there's a lot happening in progressive surgery that falls beyond the basic circuitry. So I wouldn't overpromise.
Is that for you? Yeah.
Thank you very much. Oh, you're welcome.
I just finished reading a book you also might be interested in. Larger scale. It's by Ed Young. It's called An Immense World.
Okay.
It's all about how different beings, different creatures, animals, insects, and people